everybody to the session on mental health and autism. I'm Emily Siminoff, and this is my co-chair, Emma Nicholson, who's going to start us off.
Hi, I'm Emma Neilson. I'm a PhD student and research assistant at the University of Nottingham. I work in self-harm and suicide prevention predominantly. I also have autism. As a disclaimer, I use a mixture of personal identity first language, so I apologise to anybody who has a preference for one way of speaking rather than the other. So we know that mental health difficulties disproportionately affect autistic people. In fact, while autism isn't a mental health problem, we know that mental health problems are one of the most common and most serious challenges experienced by people with autism. As many as 8 in 10 autistic adults experience mental health difficulties, and up to 10% of adults in acute inpatient psychiatric services are autistic. So 10% of hospitalised people are autistic. To me, that is quite shocking, not least as only around 1% of the general population have autism. It's important to me as I have been in that hospitalised 10%. I've experienced the frustration of systems that don't feel flexible enough to be adapted or responsive enough to meet my needs for adjustment. I've been in that 10% and I have autistic friends who still are. Research matters to me because their experiences and their treatment matters. People with autism have a reduced life expectancy compared to their neurotypical counterparts. This is a consequence of a complex interplay of factors. So we need to think about things like perception and communication, access to healthcare and timely provision of services. Importantly, it's also due to years of life lost to suicide. So people with autism are now recognised as a group with inflated risk of thinking about suicide, attempting and dying by suicide. We don't know enough about what works in prevention and intervention for mental health difficulties in autistic populations. We know that mental health treatments may need to be adapted for autistic people, but we don't yet always know how to do that. People with autism are often not identifiable in existing data sets, and this limits our ability to determine whether treatments, prevention, intervention and postvention strategies designed for the general population apply equally to autistic populations. The number one research priority for autistic people, families and researchers is finding and adapting interventions to improve mental health. Today is therefore an exciting opportunity, and an important one, to hear from some of those pioneering endeavours to further our understanding of not just what works for people with autism, but also why. So thank you for joining us today.
Thanks. Thanks very much, Emma, for kicking us off. I'm really just going to add to that it's now been over a decade since we've recognised that one way of thinking about many challenges experienced by autistic people is that they have additional mental health problems. What we've been able to do since that recognition is not only show remarkably consistently that those rates of mental health problems are significantly increased in people with autism and autistic conditions, but also begun to explore what might be some of those underpinning mechanisms for different conditions. And that work is absolutely crucial in order to understand why those rates are so increased, and therefore what might be the ways in which we adapt interventions. Really importantly as well, the autistic research population has recognized the critical nature of bringing autistic people into identifying what are the important questions to ask and what are the kind of outcomes that are most important for autistic people. They shouldn't be decided and designed by researchers, but always with autistic people and their families in mind. And I think the topics that are covered today really will deal with some of those issues. So just a little bit of housekeeping. We have variable length of talks today, including some very brief ones, and I know people will be challenged by their timings. Emma and I are going to be ruthless timekeepers for all of you so that everyone has a chance to present. We will aim to have 2 minutes of questions for each of the speakers, and Emma and I will have a 3-minute and a 1-minute warning for the speakers. So let's get going. And our first speaker is Monique Botha. Monique. Can we have it on the screen? Oh, this one.
Wonderful. Hi guys, so my name's Monique Botha, soon to be Dr. Monique Botha, hopefully. Give it a few more months. And I'm very excited about that because it's been years in the making. So I'm going to discuss the utility of the minority stress model in understanding poor mental health and suicide in the autistic community. And as part of that, I'm going to also be discussing autistic community connectedness as an under-researched, underutilized resource. There we go. So what I'll cover today, a quick introduction to who I am, how this entire research project came about, what is minority stress, why is it relevant, where we are now, because we basically got the data for 4 studies and there's a 5th one to come, and then hopefully a long and prosperous research career where I keep doing more. So my past, while I was doing my undergrad in social care practice, I was also working with autistic children and their families. Aside from that, I was working with disability and palliative care for young and middle-aged adults. Currently, I'm a PhD candidate at the University of Surrey and an autism training provider and consultant, and I'm also desperately trying to figure out what I'm going to do next. I myself am autistic, alongside like half my family and the majority of my friends. So how did this come about? During my MSc, I was researching autism, and I don't know, if you are autistic and you delve into the literature, you realize just how dehumanizing it is. Things that described autistic people as subhuman or compared them against brain-damaged monkeys disfavourably. And it was really, really alienating to be in a research environment reading the stuff that people published about people like me. Then I met a great person, Dr. David Frost, and he worked with Elon Meyer on minority stress. And I got thinking about it, and I was like, that's wonderful. But the real reason that the majority of this research has happened is because I'm a very, very petty person. Someone published a book called The Ethics of Autism, Among Them But Not Of Them. And in the book, they discuss how autistic people cannot form any form of community connectedness because we don't have theory of mind. They then also argue that that means we cannot develop meaningful friendships or relationships, and then goes on to talk about eugenics and how actually, you know, for children who are autistic, it is preferable, but once you're 18 and you've like developed the identity, well then it would be inhumane to cure you, but pre-18, it's all fair game. So anyway, there's the great book. I mean, the name's even stigmatizing, which is impressive. Anyway, so I decided to do a PhD investigating minority stress and autistic community connectedness, basically to prove one person wrong. So what is minority stress? It's social inequalities translating into worse physical and mental health. Disparities can be in, for the resources we give to that population, discrimination and interpersonal violence, systemic exclusion from societal structures. Even just saying those things aloud, I think everyone's ticking it off in their head where they're like, oh yeah, this does actually apply to the autistic community. So where do we see inequalities? So documented inequalities. So there's a higher rate of being bullied, being sexually assaulted, being subjected to physical violence, unemployment, homelessness, isolation, coercion, and rape. Autistic people are 3 times more likely to be raped than non-autistic people, for example. There's a lower rate of educational progression, social mobility, mental health, life stability, income. And as was mentioned, lifespan. Autistic people die on average 20 years before their non-autistic counterparts. And yet, no one before this had decided that actually poor mental health might have nothing to do with being autistic, but rather the way we treat autistic people. So what are minority stresses? It's victimization and discrimination, the expectation of rejection, internalized stigma, outness, and concealment. And we measured these things alongside 4 different measures of well-being and mental health in the autistic population, and this is what we found. Minority stresses predicted worse well-being across the 4 measures. 72% of the variance of psychological distress was explained through minority stress, which is huge. 58% of social well-being, 48% of emotional well-being, and 58% of psychological well-being. And basically what this means is a massive predictor of poor mental health is exposure to discrimination. So then I was like, okay, second study. What if there was something that might be acting as a buffer? Something that people haven't really looked at is the friendships that autistic people make with each other, because we have people publishing stuff saying that friendships are impossible for autistic people, or that autistic people are incapable of community. Well, actually, there's a huge autistic culture, there's a huge community out there, and what happens when you're connected to it? So I started by doing a qualitative grounded theory investigation of autistic community connectedness, and I interviewed 20 people, a global sample, using different methods. So if you couldn't do face-to-face, that's fine, we could just talk. If you couldn't talk, that's fine, we'll interview over Messenger. If you wanted the questions in advance, perfect. If you didn't want them in advance, perfect. It was really, really flexible as I could be. And even at the time, you know, a couple academics said, you know, but how are you going to get that published? Because no one will like the fact that you use different methods. And I was like, don't you think this is part of the problem of autism research? We exclude people we deem, you know, tricky to capture. And I line by line coded all of the interviews. They lasted for between 35 minutes to an hour and a half. The participant actually who talked for an hour and a half afterwards said, no researcher has ever sat still long enough to listen to me. And that broke my heart. I was like, well, then we're doing something wrong. And I built a framework from these codes. All in all, it was more than 1,500 codes, so it took a very long time. And I constructed it, deconstructed it, redid it, because I wanted to reflect it as accurately as possible. And there's a larger framework, but when you break it down to the small one, specifically looking at autistic community connectedness, what you get is 3 subdomains: belongingness, social connectedness, and political connectedness. Under belongingness, you have things like my tribe, my family, the first time I belonged anywhere. Under social connectedness, you have asking for advice, giving advice. You have going to social events that weren't exclusionary, where the lighting wasn't harsh and it wasn't loud and people understood kind of your way of being. You had being connected to other autistic people on forums, in person. You had people creating spaces. And then political connectedness. There is a massive political autistic community that we really don't give enough credit to. And part of that was autistic people describing fighting for autistic rights. They described their other autistic people as their comrades. They were advocating for equality, trying to be recognized as human. That's actually one of them. You know, one person said, I just want to be recognized as human, which I was like, Christ. So, third study, we created a scale measuring community connectedness from that. and we wanted to validate it. So in a separate global sample of 212, we used confirmatory factor analysis to see whether our new scale of autistic community connectedness would work. Then we also did multi-group factor analysis to make sure that it measured autistic community connectedness equally among various demographics. I thought I had the results, but long story short, it is a really good measure, thank God, because otherwise that's 2 years of my life. So it measures autistic community connectedness equally across genders, sexualities, ethnicities, race, type of autism diagnosed with, and whether or not you are diagnosed or suspected autistic. So it's a fairly decent measure. So, fourth study. We wanted to have a look at a cross-sectional comparison then between autistic people and non-autistic people, because our first study, the minority stress one, it was only in a sample of autistic people. Here's what we found. The difference, as you can see, in emotional well-being is huge, with autistic people having lower emotional well-being, lower social well-being, lower psychological well-being, increased psychological distress, and increased depression. All of these are significant differences with very large effect sizes, if I may say so myself, which obviously really matters. So, just looking at the depression and psychological distress there, on average, autistic participants were above the level indicating severe mental distress and clinical severe depression. That's on average, which is horrifying. Aside from this, a CAI analysis showed that there were income disparities, with the majority of autistic people living below the poverty line. Educational disparities, but it was interesting, it was bipolar. So it was like people either struggling to get what the national average would be, or you had autistic people getting as far as PhDs, but then also ending up in unemployment. You had higher rates of unemployment and relational disparities, such as higher rates of divorce. So, but are general stressful life events different? Well, yes, but not significantly so. Autistic people and non-autistic people, when it comes to general life events, it's on par. Resources, well, actually, this one's interesting. Autistic people feel like they have less control over their lives. They have no difference in terms of social support. The difference isn't significant. The difference in how much they're satisfied with that support, however, is significant. Autistic people on average feel like they matter to the world and society a lot less. But here's what's interesting. Autistic people have significantly higher resilience than non-autistic people. And yet everyone always treats autistic people like maybe if they pulled themselves up by their bootstraps, they would be able to survive some of the stuff that they deal with. Resilience, in this case, is doing nothing. And here's why. When we look at exposure to minority stresses, it is huge, even down to victimization and discrimination in the middle there, which looks like it's quite low. In actuality, that's on average, 4 events, major events. These include things like sexual assault, being beaten up, being discriminated against in terms of like the most obvious forms of discrimination, being rejected housing on the basis that they're autistic. When you look at the other things in terms of everyday discrimination, it's kind of through the roof. And those include things like people assuming that you are inherently less intelligent than your non-autistic counterparts. So, in the cross-sectional survival analysis, this is what I've got to. By the time you hit 56 on minority stress, the hazard of depression begins climbing at an alarming rate. By 94, they reach psychological failure, which I class as severe depression and psychological distress. The average culminate score in this study is 98. Preliminary results also show that autistic community connectedness increases the tolerance. So, what's study 5 going to be? Well, hopefully soon we'll know after the next wave of data collection. We're looking at how much does community connectedness moderate the relationship between minority stress and poor mental health? Does it alter the survival rate? And can we predict suicidality based on exposure to minority stress? I think that we might be able to, and that's important. What to keep in mind? The autistic community connectedness is measured to defend against discrimination, but autistic people should not have to defend against that. And yes, we're looking at a community resource, but at the same time, it would be great if the autistic community didn't experience that violence. So we still need a two-pronged approach, which includes dealing with discrimination. But also, it appreciates something wonderful about the autistic community, which is its resilience, camaraderie, and the fact that they've been left behind in research. So, thank you.
Thank you very much, Monique. We have time for one question, maybe two very brief questions from the audience.
Hi, sorry. Very briefly, how do I get this information? Because it's brilliant.
Oh, thank you. If you email me, I can...
Oh,
yeah.
Thank you.
That counted as brief, so we have time for one more question.
Don't stop until you get this on TED Talk.
Oh, thank you.
Last question for Monique while we're doing the changeover.
Anyone?
It wasn't a question. I just wanted to say how beautifully you spoke.
Oh, thank you.
Brilliant.
Thank you. That's wonderful.
So no questions and 3 compliments. My goodness. So our next speaker is Mirabel Pelton, who's going to talk to us about suicidality.
Hello? Can you hear me? I hope this will follow some of what we've just heard. Okay, so thanks for giving me the opportunity to speak here today. My research is comparing the interpersonal theory of suicide in autistic and not autistic adults. And I'm going to talk about the background to my research, the methodology I've used, the results, and what I'm really interested in is getting your views on the implications of what I've drawn from that either today in the room. Can you hear me? Better. Here in the room or on Twitter or email me, but I'm just at the stage of writing up, so let me know what you think. And I've got an alternative title to my talk, which is How Well Do Existing Models of Understanding Suicide Apply to Autistic People? And I'll come back to that in a minute and then again at the end of my talk. Okay, so there's a big body of evidence now reporting these high rates of suicide in autistic people, that they're more likely to think about, attempt and die by suicide than the people who aren't autistic. But what we don't really know is why, and there's some research exploring cross-sectional risk factors, things like abuse and depression, but we know that these are poor predictors of people who are most at risk, and this is a general criticism of suicide research, that where it's not theory-based, it's not making the impact that it should. And so the aim of my PhD research is to make sure that I'm making a contribution to that theoretical basis, so that when we're exploring questions in suicide in autism, we're doing so from a theoretical standpoint. So when we come to questions such as how can we best identify and assess suicidal thoughts and behaviours, or how can we further understand where mental health is not a factor, we're doing so from the point of view of a sound theoretical base. And these are taken from the top 10 research priorities for exploring suicide in autism, which Sarah's going to talk about later. And the third one of those I was going to mention brings up this question of models. So how well do existing models apply? So I was drawn to the interpersonal theory of suicide, I think, because it picks up some of the themes that we just heard about in the last presentation. So the interpersonal theory of suicide argues that unmet interpersonal needs are absolutely central in the development of suicidal thoughts and behaviours. And in fact, if a person feels like they don't belong, that they're completely socially disconnected, and if they feel like a hopeless burden on others, then this is what drives the desire for suicide. But a suicide attempt can only take place if that person has developed the capability for suicide, it's termed. And that is deemed to be something that you develop across the life course if you experience repeated, painful and frightening experiences. And I was particularly interested in the role of trauma because that, we know that that is more prevalent in the autistic community and it has a more profound impact. So the questions I'm asking, I'll talk about today. It's just some of the data, but I'm looking at whether this theory is useful to help us understand differences between people who are autistic and not, whether it explains differences between autistic women and autistic men, because there's research reporting higher rates of death by suicide amongst autistic women than men. And then I'm interested in these pathways. So I don't know if you can see in the picture, but I'm looking at whether autistic traits lead to thwarted belonging, whether they lead to a sense of burdensomeness, and is it this that's leading to suicidality? And does trauma lead to capability for suicide, and does that then lead to suicidality? And what I'm interested in is whether those pathways are the same or different in autistic and not autistic people. Okay, so this was an online cross-sectional survey, and repeated measures survey that I did of 865 autistic, possibly autistic, and not autistic people. And I'm just looking at the autistic and not autistic samples today. And I was, I felt the survey was successful, and I had really input in the design, really useful input and feedback in the design stage to make that survey accessible to people. But the two measures that I'll pick out here, the top one, the Interpersonal Needs Questionnaire, is a 10-item scale which measures feelings of not belonging, of thwarted belonging, and feelings of burdensomeness, and that is designed for use in the general population, specifically for use with this theory. And then if you look down the list, the Vulnerabilities Experience Quotient is a 60-item scale of the sorts of events that you were just referring to in your previous talk, of traumatic life events, so things like abuse in trauma in childhood and adulthood, negative contact with the criminal justice system, absolutely chronic financial hardship. And that measure is designed in collaboration with autistic people to represent their experiences. And in terms of what I found, similar to what we just heard, I found, and similar to other studies, I found that lifetime suicidality was significantly higher in the autistic group. And then in line with the theory, I found that feelings of not belonging, feelings of burdensomeness, and traumatic life events were much higher in the autistic group. But then the capability for suicide, I found that was the same. But this was helpful. This suggests that the theory is useful. And then I looked at the differences between autistic men and autistic women. And in the general population, in this theory, women are more likely to think about suicide because they attach greater importance to social belonging, so they feel a more negative impact, if that need is unmet. So women tend to score higher on thwarted belonging and perceived burden in the general population, and men score higher on capability for suicide. And this explains why in the general population men die more often by suicide, but women think more about suicide. Now, in the autistic population, I had hypothesised that perhaps we would see higher thwarted belonging amongst autistic women. There's literature saying greater importance of social belonging. They may be later diagnosed or misdiagnosed. It could lead to feelings of burdensomeness, and perhaps all that together could lead to more traumatic life events. And there are statistics reporting higher rates of sexual victimisation, self-harm. But in fact, what I found was that there was absolutely no gender difference whatsoever between any of the measures in this study. So none of my hypotheses were upheld. And I think what this just tells us is that the gender norms that we expect in the general population may not translate to the autistic population. Okay. And then I looked at the pathways, and what you can see here is that there was a significant association from autistic traits through feelings of burdensomeness to suicidality. And this is important because this tells us that it's not the autistic traits that are leading to suicidality, but the associated feeling of being a burden. And the same thing, I found the same thing when I looked at thwarted belonging, exactly the same. So, in fact, those feelings of social disconnection are really important. The difference that I found between... so I've shown the burdensomeness model because the difference that I found was that in the autistic group there remains a direct association. So as well as there being a path through burdensomeness, there is a direct pathway. And this could suggest that there are other factors at play. Okay. And so I tested it. And what I've shown here is that you can see that the association between burdensomeness and suicidality is much weaker in the autistic population. So though it's a significant contributor, it's weaker. And this could suggest that feelings of burdensomeness exist beyond feeling suicidal, in effect. So the association, perhaps they're more of a fact of everyday life. Or the other thing to remember with this measure is that this is a measure designed for use in the general population, so we might not be capturing burdensomeness as experienced and expressed by autistic people. I then looked at the association with trauma, and I found here that there was a direct path from trauma to suicidality, so not through the hypothesised model. Again, I found that the strength of association was much weaker in the autistic group. So you can see suicidality starts off higher, but actually, and it increases less in response to trauma than in the not autistic group. And again, if you remember, this is a measure designed by and for autistic people. So this isn't likely to be due to measurement differences here. This is likely to be due to high prevalence rates of trauma. But yes, and then so I didn't find the pathway through capability for suicide. Okay, and even though I didn't find that, I think that's not to say that this shouldn't be explored, because that concept has been accepted a bit more widely in suicide research. So just to conclude, I felt that this was a useful exercise. It's useful for understanding, for putting some context and some theoretical framework to the differences. There's certainly still a need to understand the different experiences and expression of what we might mean by thwarted belonging and perceived burden, between autistic and not autistic people. We can certainly conclude that tackling social inclusion and promoting autonomy, reducing trauma are important, and the analyses that I'll be taking on from here, so I have other data relating to anxiety and depression, which I'll try to build into more comprehensive models, but then also to do more inductive research. So we're starting with individual accounts and comparing those with current theory to explore factors that are beyond the interpersonal theory. Okay, thank you. Thank you to everyone involved. Thanks to anyone here who completed the survey.
That was an impressive and very well-timed presentation, so thank you very much for that. Has anybody got any questions?
Yeah, have you thought about looking at the impact of medical research in autism and how that trickles down into society and how people take what researchers have done, the findings that they have found, and how that's translated down into medical models and therefore society's models of autism and autistic people as a factor in your research? So not just being social, but also being fed into by academic research as well.
That might be a contributor.
So the academic research that has been done previously in autism or about autistic people, how those researchers... So,
I see.
Comparing us to monkeys, Simon Baron-Cohen, for example, calling us deficits in his research.
The sort of dehumanising aspect
but that's something that is still
there.
very prevalent in the academic circles to do with autism. That has a massive impact, I think, because it trickles down. And I wonder if that was a factor in...
Well, I think I know what you mean, and in a sense, it doesn't I guess it doesn't directly impact my research, but I think that's what drew me to this model, that I felt that it resonated out of all the suicide theories, the best one that reflected a sort of othering. But I don't know if that answers your question.
Yes, but it's also happening. sorry, it's touching on what the person said beforehand about you have all the discrimination and you have all of that happening. Do you have it happening to everyone? But then you also then go and look into this in a medical sense. You then research what it is in a medical sense, and you're confronted with you're a deficit, you're a burden, you're not good enough, you're this, you're that. You know, something was brought up this morning about having to make up for your autism, so being extremely clever, but in lieu of being autistic.
I think I mean, again, it's. I don't know if it's something that I could directly test in my research. I'm not sure how I'd do that. But certainly, you know, when you put a one line, and in the paper I've written about it, I've put more in. But, you know, when you talk about tackling trauma like that in society, you know, that's a major public policy response, not simply a bolt-on to the health service. So I don't know if that would address the sorts of concerns.
It was more just sort of like I think it is a factor that needs to be looked at, and it's more sort of not so much the research itself, but how people then take those results of that research. And
yes.
So, for example, vaccines and autism, the damage that has done.
Yeah, and because that's credible, that reinforces the situation. Yeah, I think that's what I mean by there would need to be a major public policy response across.
Okay, so is that maybe something perhaps worth looking into?
I certainly think it'd be worth looking into.
All right. But that's yeah. Okay, thank you.
I think it's so interesting what you're doing. It's really, really, really important. And I think about part of my job is to do the ADOS, and one of the questions is about bullying. And I've heard such terrible, I just want to go and cry so many times after I've done an ADOS. Most of those kids have been bullied horrifically, and many go on to have post-traumatic stress disorder from that bullying, and sometimes it happens very, very, very young. So my question is, in a way, that could be things that build up to get to the point that you're talking about. So how do you translate all of that into, how do we change everything so that it doesn't happen in the first place? How do you, I'm not saying this very well, what I mean is like, how do you, it's got to be so wide that the link between what you found and actually what happens in the classroom, in earlier settings, everywhere, how do you translate the research to a practical, clinical, grassroots, not even clinical, sort of everywhere in society to bring about change? Sorry, that's a huge question.
You just want me to redesign the world? But I know what you mean.
No, but I mean, I feel like you can't say it's not possible, because there must be things that you can do. And as a clinician, it's kind of frustrating not to see the amount of change that I believe is possible and would like to see.
Yeah, I mean, I would agree with you completely that, you know, and particularly that when I sit working through these sorts of figures, I feel exactly the same things as you do. I mean, I just sort of think, well, you know, stop it would be my main, you know, I'm not a classroom-based researcher, so I don't know what the particular interventions are, but it seems so pointless to me, that level of bullying, and that it still goes on. And it's not only punitive, you know, some of it is by teachers who are well-meaning and think they're doing the right thing. You know,
so I think we'll have to move on in just a minute, but I wanted to say that I think that's a challenging question for Mirabel, but one of the real benefits of doing high-quality research is to be able to show the impact of things like bullying, which can then lead to policy recommendations and hopefully change moving forward.
Want me just to close it?
So next up we have Ashley Robertson. He's going to talk about rates of non-suicidal self-injury in autistic adults.
Hi, so actually the title's slightly different. It's the phenomenology of non-suicidal self-injury in autistic adults. So I'm going to give quite a high level. So I don't have figures and things so much in it, but if you want more information, please feel free to get in touch with me. So just to talk about what non-suicidal self-injury is, the definition is the purposeful harming of body tissue for reasons not sanctioned by society, and specifically without suicidal intent. Autistic adults are more likely to report NSSI than non-autistic people, and we would expect to find differences based on cognitions and behaviours that are observed in autistic people. So in terms of the study, this was a participatory study, and it consisted of 4 different samples. So we have the UK autistic adults with 132 participants. We have UK non-autistic adults with 57 participants there. We collaborated with some researchers in the United States, and we had a large sample of US non-autistic college students. And we also have a group of UK self-identified autistic adults. So these are people who don't have a diagnosis but identify as autistic. They might be in the process of getting a diagnosis, or perhaps they feel that they don't want that diagnosis. But we thought it was important to include them because there's been recent research that shows that there are a lot of similarities between people who have a diagnosis and people who self-identify. So all participants completed the NSSI AT, which is administered online. And basically what we did is an item analysis, and we've used an alpha of 0.01 for all comparisons. So if they're significant, that's what we did it to. So I'm just going to quickly go through the results. So there are many different sections in the questionnaire, and the first one is forms, and this section covers the ways in which someone might harm themselves. So examples would include cutting and biting oneself, and there are 16 items. So when we look at so all of the groups were compared to the UK autistic adults. So UK autistic adults endorsed 2 more items than UK non-autistic adults out of 60. But when we used a larger sample, the US non-autistic students, there were 10 items and all of them were the UK autistic adults endorsed the items significantly more frequently than the US non-autistic students, whereas there were no differences with the UK self-identified autistic adults. When we look at functions, there were 14 items across 5 different subscales, and this section covers why someone might engage in NSSI. And examples include to change emotional pain into physical and to deal with frustration. So again, when we do the comparisons, we find the same pattern. So there was 1 subscale and 1 item of difference for the first group, 4 subscales out of 5, and 10 items out of 14 for the US non-autistic students, and there were no differences for the self-identified autistic adults. When we look at initial motivations, so this covers the initial reason that someone would give for engaging in NSSI, and examples include discovering it accidentally or trying it after being upset. And there's a slightly different pattern here with far fewer differences. So there was 1 item that was different for the first group, 1 item that the UK autistic adults endorsed more often, and 1 item that they endorsed less than the non-autistic students, and there was 1 item that the self-identified autistic adults identified less, which was the same one as the top group. But when we look at wound locations, and again this was 16 items, so this section covers the location of NSSI on the body, and examples include head, thighs, back and wrists. And we find the same pattern as what we did in all the other sections apart from initial motivations. So I'm just going to quickly go through the age of onset. So this question is asked when the person first self-harmed, and we found no differences for any of the groups. When we look at recency, so this ranges from So this is the time that the person last self-harmed, and it was less than 1 week ago to more than 2 years ago. And autistic adults were more recent, significantly more recent than the top 2 groups, but there was no difference with the bottom group. Same pattern with the frequency. Autistic adults reported more episodes for both of the non-autistic groups, but not the self-identified autistic adults. And they reported being significantly more likely to harm themselves than both of the non-autistic groups, but not the self-identified group. So just to summarise, autistic people report more forms of NSSI, different functions of NSSI, and more wound location than both autistic groups. There were few differences in initial motivations. Autistic people were more likely than both non-autistic groups to report engaging in NSSI in the most recent past, being more likely to engage in NSSI again in the future, and far more total episodes of NSSI. I think it was like 60% or something said that it was over 20 episodes. And autistic people and self-identified autistic people had very similar responses throughout. In fact, there was only one item that was different between these two groups, and that's really important to highlight. I'd just like to thank the project team, and I'm happy to take any questions.
So, thanks very much. We know these 5-minute talks are really challenging to do and get a message across. I think we have time for one quick question. Yeah, over
there. Do you attribute the gender imbalance in the male and female participants of the survey?
I think that generally with online studies you do find that women tend to respond more than men. I think we've found that consistently across all of our studies. It would be really good to have a more balanced sample in order to, properly look at the genders. But yeah, I think we've found in all of the online studies that we've done that there is a preponderance of females responding to it. Yeah.
I think we will have to leave it for now. I can see lots of other questions, but people can catch Ashley later. Our next speaker is Hannah Pickard, who's going to talk to us about anxiety.
So, hi everyone, my name's Hannah and I'm a PhD student at King's, and today I'm going to talk to you about one study from my PhD looking at mechanisms associated with social anxiety in autistic and neurotypical adolescents. So, social anxiety is commonly characterised as an intense fear of social situations where an individual may feel like they're being negatively evaluated by other people. And the mechanisms we're interested in looking at are intolerance of uncertainty, sensory processing differences, difficulties with emotion regulation, and also alexithymia, which is commonly characterised as a difficulty with describing and identifying one's own emotional states. So we were interested in looking at which of these mechanisms are associated with social anxiety in autistic and neurotypical young people, and also whether there are some mechanisms that are specifically associated with social anxiety in autistic adolescents compared to neurotypical adolescents. And so for this study, we had 61 autistic young people and 62 neurotypical young people who were recruited for this study based on anxiety. And they all had a full-scale IQ greater than 70 and a word reading age greater than 10 years old. So just to jump straight into some of the results, given that we only have 5 minutes. So firstly, we saw no significant differences between autistic adolescents and neurotypical adolescents on self-reported mental health problems, including social anxiety. However, we did see that parents of autistic adolescents reported significantly greater externalizing and internalizing problems compared to parents of neurotypical adolescents. With regards to group differences in our mechanisms of interest, we saw very similar patterns across our autistic and neurotypical adolescents. The only significant differences we found were that neurotypical adolescents reported greater sensory hyposensitivity, and parents of autistic adolescents reported greater intolerance of uncertainty than parents of neurotypical adolescents. So what I'm showing you here is the associations between our mechanisms of interest and social anxiety split between our autistic adolescents and our neurotypical adolescents. And what we can see here is a very similar pattern of findings across both of our groups. So we see that increased self-reported social anxiety is associated with greater alexithymia, greater use of maladaptive emotion regulation strategies, greater sensory hypersensitivity, and greater intolerance of uncertainty, as reported by both child and parent. The only difference we see here across our groups is that increased social anxiety in our autistic adolescents is related to sensory hypersensitivity, where this association is not found in neurotypical adolescents. but just to highlight that these two associations are not different across these two groups. So given that we see a very similar pattern of results in terms of the profile of these mechanisms across our groups, and also the associations with social anxiety, we decided to combine our groups and take a more dimensional approach to look at how these mechanisms might explain the relationship between autistic traits and social anxiety symptoms. And I'm going to show you some of those findings now. So in our total sample combining both groups, we see that autistic traits significantly predicts social anxiety symptoms. However, when we look at our mechanisms, we can see that intolerance of uncertainty as reported by a child significantly explains this relationship between autistic traits and social anxiety, as that pathway is no longer significant. We also see that intolerance of uncertainty as reported by a parent explains this relationship between autistic traits and social anxiety symptoms. Again, we also see that alexithymia explains this relationship between autistic traits and social anxiety symptoms. And finally, we found that sensory hypersensitivity, so increased hypersensitivity, explains this relationship between autistic traits and social anxiety symptoms. And what this suggests to us is that intolerance of uncertainty, alexithymia, and sensory hypersensitivity might be kind of key risk factors for the development of social anxiety in autistic and in neurotypical adolescents, although bear in mind that this is a cross-sectional study. So just to summarise, I hope these findings go some way towards helping us understand a bit more about the etiology of social anxiety in autistic and neurotypical adolescents, as we don't have much work to date. And I also hope that this research can help us to understand a bit more about how we might be able to adapt interventions to help treat and alleviate social anxiety both for autistic and neurotypical adolescents. And these findings suggest that maybe targeting specific mechanisms, for example, intolerance of uncertainty or sensory processing differences, may be key to alleviating social anxiety for these individuals. I think there's three things we need to do next. Firstly, we need to build a better picture of what the probable etiology of social anxiety looks like for these individuals. We also need to extend our findings and replicate them in different age groups to see whether the same mechanisms are associated in younger and older individuals. And also do more qualitative research to understand more about how social anxiety develops in autistic young people. So thank you very much for listening. I'm happy to take any questions.
I think we've got time for two relatively brief questions.
To what extent are alexithymia and emotion regulation connected, given that if one can't describe one's emotions, how can one regulate them?
Yeah, I absolutely agree. And a part of this project I want to look at is how together alexithymia and emotion regulation predict increased anxiety for autistic individuals. And I think combined that there will be additional problems when you're looking at anxiety, particularly if you can't identify and describe your emotions, then how can you regulate them in stressful situations? But that's definitely something that I hope to do in the future.
Does anybody have one final question?
Thank you. This was really interesting. Just two short questions because I didn't get two parts actually. So you kind of said the sample size and your aims, but I didn't actually get how was this tested? Like, did you do interviews, surveys?
Oh, sorry, this was questionnaire based. We did some of it was experimental, but I haven't presented here. But mainly self and parent report questionnaire where we could do parent report.
Okay, and your answer to your second aim when you said that you wanted to see whether autistic people have like specific mechanisms, like what's the answer to that question?
So when I showed the associations, we see a very similar pattern across our autistic and neurotypical adolescents, and we were looking for any differences there, but we see a very similar pattern, which perhaps suggests to us, although obviously bear in mind this is cross-sectional, so you can't assume causality, that there might be very similar drivers of social anxiety across the autistic and neurotypical adolescents. But I think we need to delve a little bit more into this and look across different age ranges as well to see whether that's the same across development.
Thank you.
Thanks. just to mention, I am leaving now, so if you do have any questions, do email me or send me anything on Twitter. Thanks very much.
I'm just going to deviate from what Emma and I agreed, and while Emma's very helpfully getting the slides up, since I'm so rotten at that, I'm going to introduce Samantha Hall as our next speaker. Sorry, Izzy. Isabel Yorke from my own section. My goodness. Right. My notes are incorrect. I need to look rather than read.
Good afternoon, everyone. So I'm going to be presenting research that we've conducted on the associations between child and parent mental health in families of autistic individuals over time. So, as we all know, autistic young people are at high risk for emotional, conduct and ADHD symptoms and other mental health difficulties. And as you'd expect, their parents play a key role in supporting their children through these and other difficulties. And we've heard today a bit about some parent-mediated interventions to support children's development. However, parents themselves are also at increased risk for mental health problems in this population. And my focus was to understand how parent and child mental health problems might be associated over time. In the general population, we know from quite sophisticated research that levels of parent and child mental health are related. They're risk factors for one another, such that improvement or deterioration in one can predict similar changes in the other. In families of autistic children, research is at a much earlier stage. There is limited longitudinal research out there that can address these kind of predictive questions, but this is all based on parents reporting on both their own mental health and that of their child. So with this in mind, our aims were to investigate these longitudinal associations whilst using multiple information sources on child symptoms. So we conducted this research in a sample of 101 children with an autism spectrum diagnosis and their parents. The children were part of a wider study based in Lewisham and Bromley, and the children had to be born within a particular year range. And time 1 was conducted when the children were 6, or a mean age of 6 years old, and time 2 was conducted at age 13. So as I've said, we had a focus on collecting a variety of measures. Parents gave us information on their own mental health problems, those of their child, and information on their child's autism traits. Teachers gave us information also on the children's mental health difficulties, and we did direct research assessments to assess the children's autism traits and learning ability. And we analysed this data using path analysis, which allows us to assess whether data fit a particular model. So in this model, we can see all the potential relationships between the different traits of interest, both at individual time points, so correlations, and also prediction from age 6 to age 13. So we're particularly interested in here as to whether these predictive paths are supported by the data. So we analysed this model separately for child emotional symptoms, conduct difficulties, and ADHD symptoms. And just a note that these are predictive paths, not necessarily implying causation. So this is our final model for emotional symptoms with non-significant paths removed. So the important path to notice here, given our research questions, is this one, which tells us that child emotional problems reported by teachers at age 6 predicted parent mental health problems reported by parents themselves when the children were older. Moving on to our model for conduct problems, we saw the reverse association between earlier parent mental health problems, predicting later child conduct problems reported by parents and by teachers. However, when we looked to the model for ADHD symptoms, we saw no paths leading from one to the other. So these preliminary findings show that the predictive association between child and parent mental health is possibly observable in both directions. And this research, I think, may guide future work on designing autism-specific interventions for promoting both child and parent mental health. It's important to consider parent mental health when we're designing these interventions and looking at it alongside child mental health as well. I'll leave it there. Thank you to the team, and any questions?
Thanks very much, Izzy, for keeping to time. And questions for Izzy? No? Should we move on to our next speaker? Fiona Knott from Reading is going to give our next talk.
Thank you. So, yes, I'm Fiona Knott. I'm a clinical psychologist and I work here in the university. And I'm going to talk about a qualitative study that we've run here in the Centre for Autism with our placement students and master's students. So we're particularly interested in anxiety. I mean, as a clinician, it's a no-brainer to say that anxiety is a huge problem for autistic children and adolescents. And we know that that the prevalence of anxiety is really high. If you look at the research, which is exploding in anxiety at the moment, actually the vast majority of it is carried out with regard to verbally able individuals, and there's almost no research that helps us understand how you recognise anxiety in children who don't speak or don't have words yet. And I think as a result of that, there's very few treatment options. There's a tiny number of papers that actually help us think about what you can do to help support children who are non-verbal. So we decided we needed to run a bottom-up study trying to start thinking about this. So this is the first kind of attempt to start thinking about anxiety in this group. So we ran a couple of focus groups with parents and 2 with teachers, just asking very open-ended questions about how do you know when your child's anxious, what do you think's led up to it, what do you think are the factors that are responsible for that, and how do you deal with it? We've analysed this using thematic analysis, and what I'm going to show you today is just some of the preliminary themes that are coming up from this thematic analysis. And there are real overlaps in what parents and teachers say, but there are also some differences, and in a way the differences are the things that I'm picking up on to try and think about what we do next. So the first thing that comes up from everybody is this is just hard. So parents, the impact of anxiety, parents talking about when she gets going, there's not a lot you can do, she's so strong, she's thrown me, if I'm pinning her down, she can throw me off her. This is a mum talking about a really tiny child and how strong she seems to become. Teachers also talk about the impact and how hard it is, and what they were talking about, this particular teacher saying if you try to stop them, you try to stop them because it's so awful, but you know that when you intervene it's going to make it worse, but you can't not intervene because they're hurting themselves. So this dilemma that teachers were experiencing is one of the things that they talked about. They also, both groups talked about this is just hard to understand. It's really hard for us to work out what's going on and what we should do. So parents talked about lack of consistency. So you think you know what's going on, but it varies from day to day. So what might be triggering off anxiety varies from day to day. And then another parent talked about trying to understand her child who doesn't have words, so the words aren't there for her to get the emotion out. And teachers similarly reflected on things like trying to unpick the behaviours, working out what's bloody mindedness and I can't be bothered because it's Monday from anxiety, and I think that's something that came up quite a lot. And also changing behaviour. So a child might be seeming to be very calm 1 second and very anxious the next moment. There was huge agreement over the signs of anxiety. So the words that are the biggest are the themes that you would predict have the most kind of support. So recognising the child's anxiety through aggression or self-injury being the most common reported and the most worrying sign for parents, but also things like withdrawal and refusal. And then what causes anxiety and the triggers of anxiety, sensory was by far the biggest thing that people talked about, but also what I've just called physiological, because I can't think of a better word, but that means things like epilepsy or puberty or a kind of medical conditions that might be going alongside the autism, as well as things that we'd all predict, so change and waiting. But what also came across from talking to people is how they all interact. That was something, it wasn't just that you think of one thing might lead to something else that might lead to something else. So lots of agreement, but there were also differences, and actually it was in the way people talked about how they dealt with anxiety that was the challenge. So both parents and teachers talked about the fact that sometimes you just have to let the child self-calm, and they actually talked about how children have their own strategies for self-calming and you just have to let them get on with it. But actually, the other way that it was different was that teachers talked a lot about things that you could do to prevent anxiety, and they were very strong on that. So they talk about structure and building strong relationships and helping a child by taking tiny steps and just persevering. They were very good at that. What parents were very, very good at talking about was what you do when there's an anxiety episode going on. So they were very good at coming up with distraction techniques or thinking this is when I'll reduce the sensory input, or frankly moving other people away so that everybody stays safe. But a real difference. So it was very striking that teachers think about what you do before the anxiety, and parents are good at thinking about what you do afterwards. So that's really... one other thing, that they also talked about challenges of working together. So, because obviously that makes us think you need to kind of get people working together. And teachers said, when it's consistency across settings, that's when you see improvements in children. But parents are saying, it's so hard for us to do that. So parents are saying, school, they've got structure, they've got the equipment, they've got the staff. We haven't got that at home. One mother I remember said, visual timetables are wonderful, but I can't get my kid to wear her glasses at home, so she can't see them. So, whereas she was wearing them at school. So trying to help parents and teachers work together, I think, is a primary thing for us to think about. And that's really where we're going. So for our next steps, clearly we need to understand more about anxiety and its impact, that's a given. But what we're trying to do now is develop workshops for parents and teachers to work together in thinking about a child's anxiety and coming up with strategies jointly, where they have a kind of joint formulation of what's going on, and then you can use strategies that cross this bridge from the great strategies that teachers use to the very effective ways that parents are supporting children when they are anxious. So those are our next steps. So, and thank you to the team of parents and teachers and the research team who carried out the research here.
Thank you, Fiona. I think we've got time for one quick question if somebody has one.
Thank you, Fiona. That was really, really interesting. I was just wondering how you found parents and teachers kind of actually recognising anxiety, because it sounds really encouraging that they were able to recognise some of the behavioural challenges for their children as anxiety, because we find that often parents and teachers don't necessarily attribute those things to anxiety. So just wondered if you could say a bit more about that.
I mean, that's something that we need to look at a bit more closely and look at, while we've got these big themes that they're saying, yes, it's sensory, they were very clearly saying, this is sensory because I'm worried, or this is challenging behaviour because I'm worried, rather than because actually I just don't like doing maths or whatever it is you're expecting me to do. I can't answer that question now, because I actually need to look at the data in a bit more detail to kind of find out what they were highlighting that made it very clear that it was anxiety. We kept on in the focus groups going back to saying, are you sure this is anxiety, rather than just being bored or tired or fed up. So I think it'll be in there, but I need to do a bit more mining to find out.
But it's good that they were even thinking about anxiety at all, so that's great.
Yeah.
Thank you.
Thanks.
So next up we have Melanie Palmer, who's going to be speaking about a protocol for testing a novel group parenting intervention to reduce emotional and behavioural problems in young autistic children.
Thank you for that, Emma. So in the next 5 minutes, I'm going to talk about a study protocol of a trial of parent-mediated interventions for mental health and autism. So the A-STAR trial is a pilot randomised control trial which followed a feasibility study of newly developed group-based parent interventions. So the target intervention is called predictive parenting, and it aims to reduce disruptive behaviour and anxiety in 4 to 8-year-old autistic children. And it was developed with input from autistic adults and parents of autistic children. And we're comparing predictive parenting to another parent psychoeducation supportive group. So this intervention does not specifically address disruptive behaviour or anxiety. So both of these interventions were delivered by the same therapists, and by using this active control condition, it enables us to explore the specific effect of the mental health content on a range of child and parent outcomes. We are also using an objective primary outcome, which is a measure of child behaviours that challenge during a structured parent-child and researcher-child interaction. And the researchers are blinded throughout the study. So this means that we can rate the behaviour that we observe during that interaction without knowing what support the family has received. So this enables us to overcome some of the limitations that there are when you use parent reports, when parents know whether they've had a specific intervention or not. So this slide shows the flow through the study for the pilot trial phase. So the first assessment involves children and parents completing a number of direct assessments, interviews and questionnaires. And teachers are also asked to complete a short questionnaire. We also directly assess children's autism traits, and other measures are used to characterise the sample. Once the initial assessment has been completed with enough families to form 2 groups, families were then either randomised to the parent psychoeducation supportive groups or predictive parenting. And both of these consist of 12 weekly 2-hour sessions, and they are both differentiated by child verbal ability. So parents with children who had fluent verbal speech attended a group together, and parents of minimally verbal children attended a group together. After the intervention has ended, most of the assessments were completed again, but we also sought measures related to the intervention. So prior to conducting the pilot trial, missed a slide there. We did some feasibility testing. So this feasibility testing aimed to inform how we were going to conduct the study, and we wanted to learn a bit more about these specific areas. So we also got independent feedback on the interventions, but as I'm one of the researchers on this study, I'm still blind to the intervention content and allocation, so I will not be talking about that. And there were 3 key changes we made as a result of the feasibility testing. So others who are involved in conducting trials of group-based parent-mediated interventions might benefit from considering these areas in future trial protocols. So these were our 3 key changes. So we increased the group size from 6 to 8. So this was a more efficient way to recruit and deliver the interventions, and it was thought that slightly larger group sizes would be helpful for group dynamics, particularly if we had a couple of families who were unable to come to some sessions. This change in group size then impacted on our recruitment and randomisation procedures, and we hadn't tested how randomisation would work. But if we wanted to have groups of 8 families, we needed 16 families to have completed the first assessment within a 2-month time frame and be available to attend either of the 2 interventions to be able to randomise. And we also got independent feedback on the research procedures as well, as part of a qualitative component. And we use this feedback to adapt our procedures. So, for example, some parents felt that the assessments were too long, so some of the questionnaires were dropped to reduce measurement burden. So I hope that findings from our feasibility testing and the development of our protocol would be helpful for others who are involved in other trials of parent-mediated interventions. And we have now successfully completed our pilot trial, and we're hoping to publish our findings very shortly. Thank you very much to all of those involved, and I'm happy to take questions.
Thanks very much, Mel. Questions for Mel? Questions? Nope. We can move on to our next speaker then. We heard earlier about intolerance of uncertainty as a potential mediating mechanism in anxiety, and Jane Goodwin's going to talk to us about living with intolerance of uncertainty.
Thank you very much. Just wave if I'm not speaking loud enough, because I know I can get quite quiet, so just let me know. So as we've heard a bit this afternoon, we know that anxiety is a really big issue for autistic children, and we think it affects around 50% of autistic children. And anxiety might be related to intolerance of uncertainty. So that's an assumption that uncertainty is stressful and upsetting and it should be avoided at all costs. So that could be things like not being sure which aisle you're going down in the supermarket first, or which team is going to win the soccer match, those kind of things. So as we've heard as well, intolerance of uncertainty seems to be a really important mechanism in both the development and the maintenance of anxiety in children and in adults. So there's been a bit of work done by Dr. Jackie Rogers' team at Newcastle about this, and they found that intolerance of uncertainty is recognisable to parents of autistic children, and it's associated with their child's anxiety. And that was done with quite small numbers. And they've also found that intolerance of uncertainty is associated with anxiety and repetitive behaviours in autistic adults. So what do we not know? I don't think I have enough time to talk through everything I don't know about, but just to give you a brief summary is that most of the research that has been done on intolerance of uncertainty and anxiety in autistic people has been done using questionnaires that are developed for non-autistic people. So we're not quite sure if they really fit properly. And we also don't know a lot about when intolerance of uncertainty is really tricky. So a lot of the work that's been done has been done with community samples, but we don't know a lot about people who are recruited from clinical services, so are really experiencing a lot of anxiety. We don't know a lot about what the real world experience of intolerance of uncertainty looks like. And we don't know what the impact is on the child and on their family and on their friends and that kind of thing. And we also don't know how children and their parents and the families respond to uncertain situations. So we need to know all this information to try and figure out what interventions are appropriate to help reduce that anxiety. So the objectives of this study are to identify the types of uncertain situations that cause difficulties for autistic children in their daily lives. We want to find out a bit more about their responses to these uncertain situations, and we want to explore how intolerance of uncertainty kind of impacts on daily lives for autistic children and their families. So what does it mean for the families? What does it look like? So this is just some preliminary data. So we've got 41 parents here. At the moment, we've just recruited our 52nd participant, I think. So we will be updating these results. But So we've got 41 parents of autistic children who are experiencing some anxiety, and we've recruited these through clinical services. So it's those children who are experiencing a few more difficulties with their anxiety, and it's all from the northeast of England, and it's part of the CUES trial, which I won't go into now, but please do feel free to contact us if you've got any questions about that. So we got the parents to complete a few questionnaires, so a questionnaire about their child's intolerance of uncertainty, the anxiety that their child experiences, and they also were asked about 2 situations that their child finds difficult because of uncertainty. And where possible, so if the child was able to and wanted to complete questionnaires, they completed questionnaires about their own intolerance of uncertainty, and about their own anxiety in general. And the measures of anxiety are free to download on the link there. So this is just to give you a picture of what the people looked like who were taking part in this study. So in the intolerance of uncertainty scale, this was scored out of 60. And when we look at the averages, parents reported that their child had a score of around 46, and when the child talked about themselves, they reported about a 45. So they're very similar, and it's quite a high level of anxiety. And you can see the same in the Ask ASD, so there's quite high levels of anxiety. I've got the total scores on the left-hand side, and then the parents' average score for their child, and then the child's average score for themselves. And the little asterisks here and here indicate that these are above clinical cut-offs for anxiety. So you think you might have an anxiety disorder if you've got a score of around 20. So you can see that these people are experiencing a lot of anxiety. So when we asked about the situations that were difficult for families because of uncertainty, we came up with a few different things. So there were school-related anxieties, which seemed to be the biggest one. So they were things like getting in trouble at school, getting the homework done, not being sure about the routine, so would the teachers change what was being served for lunch that day, all those kind of things. Then fun and spontaneous events were also tricky because there were things like going to parties or just going on fun family days out because the child wasn't sure what to expect, how long they'd be there, how many people would be there, would it be noisy, those kind of things. And then there were enjoyable activities, so a lot of kids really wanted to do after-school clubs, but they couldn't really take part or found it really tricky because they weren't sure whether they would get dressed in time or how many people would be there or what the specific activity would be for that day. There were some worries about essential tasks, so these were things like going to the supermarket or going to doctor's appointments or catching the metro to college, those kind of things. Then there was one about having visitors over, so being worried about how long people might stay over at your house or what they might touch or how long you'd have to kind of spend time with them. And there are also worries about parents sleeping out for the night. So if the parents had a night out for their anniversary or something, the child might be really worried because they didn't know what time mum and dad would be home. Would something bad happen to them? Would they be okay? All those kind of things. And then 2 of the situations identified were due to sensory things, so not wanting to try new things because they weren't sure what they'd taste like, or not wanting to change their clothes or even being too scared to try new clothes because they could be uncomfortable. So we kind of looked at these in terms of how the child reacted to the uncertain situations, what the impact was on the child, and what the impact was on the family. So looking at the child reactions, they reacted in different ways, and of course this varies between the individual child themselves, but some themes we came up with were avoidance, so they tried not to go to the things that were really scary for them. They also had some affective responses, so they could become hyperactive or they could become really withdrawn and quiet and not their usual self. The children could also have behavioural responses, so ask lots of questions over and over and over, even though the answers were going to be the same. And they might need to check that everything was ready for them to go to their activity, or create rules to kind of make sure, Mum, if you go into the supermarket, you can get 3 things and we need to be back in the car by past, those kind of things. And, as well, they do things like absorb themselves in their special interests and passions to make themselves feel better. So the impact of these uncertain situations on the child were negative responses from other people. So they might be reacting in a certain way because they feel so worried about something, but then they get in trouble from their school teacher or from their parents for behaving that way because not everyone quite understands. Or they might get invited to a party and can't get through the door because it's just too much for them, and then their friend's really angry with them because they didn't show up. And they just can feel really upset and devastated and maybe experiencing this kind of extreme roller coaster of emotions, so being really excited about something but really scared at the same time. And it stops them from enjoying activities or doing activities that they really want to do. And this also impacted on the family in a lot of different ways. So there was the emotional impact, lots of worry and guilt and fear. And a lot of parents mentioned that they wish they had a magic wand just to take away all those worries. And there was lots of extra things that needed to be done, like planning and providing reassurance and all those kind of extra things that they needed to do to help the child worry a bit less. So what this means is that there's a variety of situations that interfere with child and family functioning that are related to intolerance of uncertainty. And lots of those situations were unavoidable, for example, school. And our results will hopefully help us in the development of anxiety programs. So we really want to make sure that people can be able to tolerate some uncertainty so we don't have to over-prepare or we don't have to avoid things that we really like to do or really need to do. And as you will have seen, school is a great source of anxiety for a lot of these children, and at the moment we're looking at programs to help parents, but we need to kind of take that into school. So if anyone has any comments or suggestions about that, they'd be very welcome. And just thank you to everyone who took part, and thank you to Autistica for funding this study. And thank you very much.
Thank you. We've got 2 minutes for questions or comments. Emily.
I have a burning question, but I was checking whether anyone else did. So as you were talking, I was really interested to hear some of the things you were describing as intolerance to uncertainty, because I was thinking, well, that's what I think of as separation anxiety or whatever. So the example of worrying about what's happening to the parents when they go out at night, or whether someone's going to be in the school canteen or whatever. How do you, in your mind, separate the worry about the thing?
Yeah. So
something bad might happen to mum and dad, and that's what's the driver, as opposed to I don't know whether it's going to happen, and that the uncertainty about anything that isn't happening in the here and now is, of course, uncertain. So how do you phenomenologically or philosophically distinguish those two?
That's an excellent question, and I will try my best to answer it. But I think, for me, it's quite difficult to separate the two, because I think intolerance of uncertainty is really involved in all those kind of different anxiety labels that we've got. So for me, I would think intolerance of uncertainty could be related to separation anxiety, in the fact that you're not quite sure what's going to happen to mum or dad if they're not with you. So I think they're very similar things to mixing up my words, but they're so intertwined that it's really hard to separate. But I think the crux of intolerance of uncertainty is that you don't know what's going to happen and you don't like that's happening. So you could be separated from mum or dad and just know that they're going to have a lovely day out and not be worried that something bad is going to happen to them. But then intolerance of uncertainty could come into that because you're separate from mum and dad, and you might worry that they might be in an accident or something bad could happen to them or they won't come home. So I'm not sure I've done a very good job of answering that question, but it's really hard because they are so intertwined.
I think we've just got time for one more, so everyone else's hands have shut up. Maybe if you can catch afterwards.
Hi, I'm myself are awaiting an autistic assessment. I'm also a head teacher of a small school for children a secondary age with autism. One thing that seems helpful for the majority of our children are social stories. Yep. And if we are able from school into home to teach parents about social stories, that seems to happen, because the children, the families might think, oh, we're going on a nice trip, but actually that child has no idea whatsoever what those people, the parents, are actually doing. So little drawings even just help to ground the children.
Absolutely, yes, thank you very much. And yes, and it's thinking about the things that we might not think are uncertain, but other people might think about it as well. So, yeah, thank you.
Emma's been doing such a wonderful job on the slides. Our last speaker is Sarah Cassidy on suicidality.
Thank you, everybody, for the absolutely amazing talks today. I'm just really, really blown away by how much further we've come from just a few years ago. No studies on suicidality and maybe just a few small-scale studies on rates. And moving beyond that and trying to really, really understand why this is happening, and just taking us that bit closer to thinking about prevention, which is so important. And it really, really kind of helps me in talking about this topic, which is where do we actually go from here in terms of understanding and preventing suicide. And this morning in the PPI session, I was really, really trying to make the case that this is so important to do in partnership with those affected by the research. So I'm going to tell you a bit about, in a very, very quick time period, what I've been doing over the past 3 years to try and draw attention to this issue, but also to work in partnership with autistic people to ask, what should we be looking at? What should we be researching, and how should we be researching it? And I really, really want to stress that I think that this is an ongoing process. And even though we have identified a top 10, I think that we should continue this process and continue fleshing out these top 10 and furthering them on as we get more research findings in. So this is not the end, and it's not written in stone, it's the beginning. I just want to stress that. So we know that anybody from 2 different perspectives will look at the same issue in very, very different ways. And this is borne out in research. So the Future Made Together report and excellent work from Sue Fletcher-Watson and Liz Pellicano and colleagues showed that the research actually happening didn't reflect the priorities of the community, autistic people, their families, and those that support them. And it's really, really important from that report that we work with those affected by research to make sure that the research that we do is actually useful to people. So at the beginning, because there was so little research on suicide and autism, the first kind of impetus and first thing that I thought that we had to do was ask autistic people, what should we be researching? Are autistic people and those who support them, are they happy to support research? Are they happy to take part in research? Is there buy-in for this research? How should we do it? It was a really kind of blank slate. So what I've been doing over the past 3 years or so has grown organically. So that's another thing that I want to stress. It's grown organically. I've had one opportunity that led on to another opportunity. So it's not kind of pre-planned. I just started it thinking, well, let's just see where it takes us. Let's just see where it goes. So this wasn't kind of planned from the start. It's something that's evolved organically with the really, really kind and unfledgling support of many autistic community members. So I want to say thank you from the start. So how did it start? I was very fortunate to get support from the Economic and Social Research Council New Investigator Award a few years after my PhD and the National Institute of Health Research. And it allowed me to run some public engagement workshops. So I just invited people. I said, please come visit me and tell me what you want me to research. And it was really, really open. And through those two kind of open public engagement events, I had 60 people total that were really, really interested in talking to me about what I should research. And I identified some really, really kind of broad issues and some ways of working. And what it really, really helped me to do as well was to generate and demonstrate buy-in, which was so important, to go to funders and say, people are really, really think that this is important and we really, really have to take this a step further. So I got some kind support from the International Society for Autism Research, and that's the largest international conference each year. About 2,000 autistic people, researchers, clinicians, charities, funders go there every year. And I applied to have something called a special interest group. And what that allowed me to do in each year of the conference was just to, again, openly invite people who attended to come and talk to me about what kind of research they thought should happen. I had to reapply every year. I had to justify that I made sufficient progress to get another SIG the following year at INSAR. And in those 3 years, I demonstrated a really rapid growth in interest. Because in the first year, there were 40 people who attended. By the third year, there was standing room only because the maximum is 100. So we actually had to say, there's no room at the inn. But we got a lot of interest, and throughout all of these kind of workshops and these focus groups that involved loads of different people each year. So it's a huge number of expertise, of lived experience, people who research, people who work in clinical practice, service providers, charities, funders, and we just each year make a little bit more progress in identifying broad topic areas and then focusing in on key questions, key possible questions in each of those broad priority areas. And it just took us a little bit further. Then after that, we got support from Autistica to run the first International Suicide and Autism Summit. So we took the broad topic areas and potential questions, and we really, really fleshed it out into a long list of 48 priority research questions. And then from that, I got some further funding from the International Society for Autism Research policy brief, and in association with the James Lind Alliance Priority Setting Partnership, which was really important because that's a specific organisation funded by the National Institute of Health that specialises in helping researchers connect with those with lived experience to identify priorities. So we used a specific method, the James Lind Alliance method, to identify these top 10 from that. So what we did was we took these 48 research questions that we've done really, really wide international consultation with a variety of stakeholders over a number of years, and we did a really large online survey where we asked autistic people, their families and those that support them to rank them. We identified the top 20 from those 48, and we took those top 20 questions to a meeting, a stakeholder meeting of 30 people with equal representation of autistic people and those who support them, not researchers, just those with eyes on the ground and lived experience. And then we identified from that, we ranked them all and we identified the top 10. So that's a kind of sum of how we did the process. So I'm just going to take you through the top 10. And this is some pictures from the actual event, and this is everybody after a very, very long day of ranking, feeling like they've really accomplished something with identifying these top 10. So there are over 1,000 people, I was counting up from all the different events, over 1,000 stakeholders worldwide have helped us identify these top 10 priorities. That's amazing. So thank you so much, everybody who helped us with this. Equal representation of autistic people throughout. In fact, a big chunk of that, I would say over 50, well over 60% even, have fed into this exercise. A systematic review of the available research evidence shows that none of these top 10 have been extensively studied. And further community engagement will help develop the report that we're going to write that will be available end of 2019, early 2020 and publish on the INSAR website. So if anybody has any thoughts in relation to their experience or research or whatever in relation to these top 10, we would be interested in hearing it, because we are going to try and incorporate these thoughts into the report. So I'm going to go from 10 to 1. And so with the number 10, what is the impact of poor sleep on suicide risk in autistic people, and how can this be measured? So as an autistic person said, and there are lots of different examples, I feel it's never one thing but cumulative. And then if you add lack of sleep or trauma or PTSD, life may become unsustainable. Now we know that sleep difficulties and problems and lack of sleep is very, very prevalent in autistic people. It's a very underexplored area in itself. But what is the impact? We know that poor sleep is associated with suicidal thoughts and behaviours in the general population, but this hasn't been explored, to my knowledge, in autistic people yet. Priority 9. How well do existing models of understanding suicide actually apply to autistic people? A lot of people felt that in previous research it had been really, really piecemeal approach, whereas in a lot of the excellent presentations that we've had today, we found that it's really, really important to have a more systematic, hypothesized-driven approach to really, really understand what causes suicidality and how it could how can it be prevented. I think that we have a real opportunity here to learn from the general population regarding suicide prevention in autism and vice versa, because studying autism might reveal new things that are actually really, really relevant to preventing suicide in the general population. So learning goes both ways. Emerging evidence shows that autism and autistic traits increase risk of known risk markers, and we've heard that in the presentations today for suicidal thoughts and behaviours. Things like mental health problems, unemployment, for instance, thwarted belongingness. But there's also evidence for new risk markers, such as camouflaging one's autistic traits to cope in everyday social situations. And maybe that's also relevant to the general population too. How do autistic people seek help when they are in the crisis? As people who took part in the exercise have said, there is nothing more disheartening than being told you're not trying hard enough to find support. And I can't always communicate if I'm in crisis. We know from previous research that unmet support needs and lack of satisfaction with one's support predict suicidal thoughts and behaviours in autistic people. And we also know that support is hard to obtain, but it is truly, can be, life-saving. And this isn't just a UK issue, this is an international issue. It's found in America and other countries as well. This is a worldwide issue. It's really, really important to understand how autistic people actually seek help when they are in a crisis so we can better support them. What is the experience of suicidality in autistic people? And is this experience actually different to the general population? One example, I felt like I was having a breakdown inside, but I didn't know how to make the inside feelings show to other people. Are there different pathways to suicide in autistic people which need adapted assessment, treatment and prevention strategies? We really need to understand this in order to know what to do and how to support these people. How should interventions be adapted for autistic people in individual presentations? What works, not what's on offer, because it's always done that way. We know that there are a shortage of professionals trained in autism and mental health, lack of appropriate assessments and adapted therapies. There's real potential of adapting suicide prevention strategies like suicide safety plans, but there is no evidence for it. And by encouraging individualised treatment approaches, we can benefit everybody, not just autistic people. This is not a niche issue. How can we best identify and assess suicidal thoughts and suicidal behaviours in autistic people in research and clinical practice? This is a really, really hotly debated question because it's so important to get right. One example from our research is asking how an autistic person interpreted a question about possible suicidal behaviour in the future. How likely are you to attempt suicide someday? They said, it's a future question. You really don't know what's going to happen to you in the future. That is an impossible question to answer. And somebody else said, well, whose risk is this for? Is this for my risk or is it for the clinician's risk? Whose risk is it for? We know that there's no validated suicidality assessment tool available for autistic people, but it was discussed at the workshop, really, really important to understand the background in general suicidology, that suicide risk assessments do not accurately predict future suicide attempts. They're not cost effective. So we really need something new. We don't want another tick box that will prevent somebody getting the access to the treatment that they want because they're not answering the questions in the way that you expect. How can we further understand suicide where mental health is not a factor across the lifespan? As somebody said, it's more the autistic people without dementia being placed in dementia care due to nowhere else for them to go. There's a real concern about what was going to happen to them in adulthood. We're talking about intolerance and uncertainty in the previous presentation. So a lot of autistic people brought this up as a really, really important issue. What about suicide where mental health is not a factor? We don't know a lot about ageing. It's a really, really understudied area, and this is a real concern. To what extent are autistic people not believed about the severity of their distress? For example, I just don't show emotion the way other people do, so no one believed there was anything wrong with me or that I needed help. Who knows me best? Our narrative is often misunderstood, dismissed, and overwritten. Why is it the case that autistic people can't get access to services or they're reporting that they're not believed when they report that they're feeling suicidal? Is it because of lack of understanding and knowledge on the part of mental health professionals? Is it because of alexithymia, difficulty in articulating one's emotions and thoughts? Is it camouflaging because autistic people are so used to camouflaging their distress that when they present, it's not noticed? Why is this happening? What are the risk and protective factors for suicide and autism across the lifespan? There's lack of research into why autistic people are at risk of suicide, and that's so necessary for understanding and prevention. And it's really, really hopeful to hear the progress made here and looking at models and looking at those risk and protective factors. Things like gender, camouflaging, loneliness, sleep, support, employment, mental health. And from the talks today, there are more factors that can now be added onto this list. Priority 1, what barriers do autistic people experience when seeking help which may put them at greater risk of suicide? As in our paper in 2018, People Like Me Don't Get Support is the title of the paper because it really, really encompasses how autistic people felt when they tried to access mental health services. Attitudes towards me, attitudes about me, the current system, being dismissed, no autistic pathway. I was really shocked to learn when I was reading Autistic's website in their recent report that there's no funded service delivery research in the UK in 2013 to 2016, despite being a community priority. It's a really, really important issue that needs to be addressed. So where should we go from here? I would argue that co-production is not optional. We need to close the gap between community priorities for research and what is actually funded and researched, what will make a positive difference on the ground. And I think there's a real learning opportunity between autism and suicidology research to make things better for everybody. It is not a niche issue. So thank you so much for listening and for staying to the end of the presentations.
Thank you. We've got time for a question or two before you get to have your coffee.
Hi, Sarah. I was just wondering, you mentioned several times in your talk, and also I think in your 2018 paper, that one of the issues that was given for higher suicide risk was support needs being unmet. I was wondering if you could clarify that. Does that mean support in terms of getting mental health treatment, or does it mean support with, daily living activities or being able to get out and socialise and things like that, or do you mean both?
It means everything. So we calculated unmet support needs by participants in the survey ticking where they wanted support, ideally, in a number of areas. So employment, education, work, healthcare, other. They could tick those where they wanted support, where they ideally would like it, and then what they actually got. So, I think so. Yes, I think so.
Hi. I wanted to make a bit of a general comment, ending with a question that has to do with everything that we've heard about mental health. I'm autistic and I have 5 children. 2 of them are autistic. One of my children was at a high risk of suicide when she was 12 due to bullying, and it was the most heartbreaking period I've ever had as a parent. Now she's 15 and she's very happy. And she's herself. She's offended by people saying that all autistic people mask, because she doesn't. She decided to be happy and surrounds herself with happy people. My other autistic child is 8, and he lives in autistic space, and he goes to a tiny mainstream school where roughly half of the pupils are autistic. I recently explained to him that autistic children normally have difficulty making friends, and he was surprised. And I had mental health issues, not anymore. So like your priority 2, my question is, rather than focusing exclusively on risks and mechanisms, is anyone looking at mentally healthy autistic people and what's going right?
I think that's a really, really excellent question, and it comes to the kind of not just looking at risk, but looking at, what are protective factors, what, helps people, thrive. As far as I know yet, there isn't a lot of research in that area, but it's an excellent point and an excellent avenue for future research.
I think we probably need to end the formal questions now. We're over time, and I know you'll be desperate for your tea. Can I thank all the speakers who've given us such excellent presentations and kept to time? And we've got through a lot of very, very interesting findings. So please join me in thanking everyone. Thank you.